I hope I'm audible now. We are starting the session, okay? And we'll be just starting in another 2-3 minutes, okay? So I hope I'm audible, visible. Only minutes for the link. Okay. So hello, all of you. Okay. So hello, all of you. So we'll be starting the session soon, okay? And I'm with Dr. Areez, okay? And Areez is a proud student. We'll be starting the session soon, okay? Voice. And I'm with Dr. Areez. So Areez was not only my student but a dear brother also. Okay, clear. Last session I told you we had students. We did a session in October, November, December for December exam, and I had no faculties except Sara, Areez plus other team members, Dr. Pooja plus all were there, and they helped us make students pass. Okay, clear. We are also helped by Dr. Azam, then also by Dr. Sushant, Dr. So many people. Okay, Garima. They all helped us. Okay, in the last session. So this time we are trying to continue further and have what this session basically to make sure that we are able to make sure that you all are able to revise the subjects properly. Okay, so revision means what? Even if you have very little knowledge of orthopedics, you'll still be able to understand lots of things, and that will help you what get a very good score. So idea is what? First we'll do what? The revision of the subject, okay, and then we'll have a question session with Dr. Yusuf, because same person doing the discussion will be much easier. But let's check what is there in terms of actual question asked in the exam. So he'll be discussing actual questions, and we'll be discussing the actual main theory. This theory which Dr. is doing is from the best possible sources that we are having right now. Okay, clear. So I'll be giving over Dr. Areez, okay, and he'll be making sure that all the important, at least 4 MCQs out of 5 are there in the notes, okay. So don't worry, PDF would be up, everything you have, he will be helping, because not first time, it's taking for the second time the session, okay. And all students know how important is to get minor subjects done on time. We're done psychiatry, physio almost over, we'll finish tomorrow physio, then ortho would be done by today, okay. So this speed will be able to finish all the subjects in the coming time, okay. So I think I'll give over to Dr. Areez.
Hello, good afternoon, everyone. Am I audible to everyone? If yes, please drop me a thumbs up. Okay, great, great, perfect. So I hope you guys are doing absolutely fine. You guys are absolutely safe and you guys are in pink of your health. I know the current situation is not really good and we really wish to see you guys offline, but then based on the recent pandemic and the second wave exposure that we are getting, it has made every one of us helpless and we cannot do anything. But then since things needs to be moved on, right? So this is the platform. We'll be seeing you and we'll be interacting with you all, right? Okay. So you guys wanna absolutely start with orthopedics? Okay, sure. Just a second. Am I better audible now? Is the volume okay?
I think it's audible now.
Am I audible now? Is it better? अच्छा हिंदी में पढ़ाओ ठीक है चलो हिंदी भी बोल देंगे बीच बीच में but the important terms which are necessary obviously they'll be taught to you in English and we'll be having the discussion in English. Is it perfect? Okay. Okay, yeah, absolutely. Okay, so definitely we'll be gossiping and we'll be talking about so many things in between. Since you guys are fresh, I hope, I don't know how to greet you all, if it's a good morning or a good afternoon for you all. Well, it depends, assuming based on the exam preparations that you guys are doing, and hopefully if you guys are dedicated, I'm wishing you a good afternoon, a very good afternoon today. And for some of you who have exception for their preparation and they have their own timings, wishing you all a very good morning. So let's start with orthopedics. I know orthopedics, when it comes to that subject, people are generally scared. But trust me, if you understand the concepts, it's pretty much very easy to get it. And it's a very scoring subject. It has got a very strong association and connection with radiology as well, right? So let's try to understand certain concepts. On paper, of course, it's a minor subject, but based on the recent exam questions that we are witnessing, we are getting approximately 7 to 8 questions. In the August attempt, we had roughly 10 questions from orthopedics itself, including the radioanatomy and the radiology part into orthopedics, right? So let me not waste any more time. Let's start with orthopedics. I hope everyone is fresh and sound. Okay, so we'll be just quickly overviewing the different terms. Don't worry, do not worry about anything. All these files will be shared to you in the form of links. I'll be sharing you my drive links. So whenever you have internet, you can easily access these OneNote files, right? Okay, so even if you're not able to jot down certain points, do not worry about it. I will be just giving you important points and important terms which are necessary in point of the examination, because orthopedics in itself is a very vast subject, right? So it's not possible to finish everything in this short span of time, but definitely we'll be covering up 70 to 75% of the major topics which is necessary for you in the exam, and which will easily give you a score of good 6 to 7 questions will be easily solvable by you guys, right? Okay. So coming to the term orthopedics, everyone knows it's the straight child. Just the history of orthopedics, Sir Nikolai Andre coined the term orthopedics, right? And Sir Hugh Thomas Owen. We have so many terms under his name. He's the father of British orthopedics. We have Thomas Splint that we use to immobilize, right? We have the Thomas test. We generally do it during the hip fractures or the posterior dislocation, right? We have the Thomas Hill, which it is the term that we use generally for the flat foot, right? Now coming to the anatomy of the bone, I'm sure everyone is aware about this. The epiphysis, the diaphysis, okay? So considering this is a bone, I'm sorry for my handwriting, I'm not used to this thing. Okay, so if you see the structure over here, this part, just a quick revision, forms your epiphysis, right? In young children, there is this section over here. This becomes your growth plate, right? Then comes your metaphysis. Metaphysis has got all the vascular structures over it, right? It is also known as the spongy part of the bone, right? And comes the strongest part of the bone, and that is the diaphysis, right? So I hope I'm clear. Both the ends of the bone will be having your epiphysis, and the same sequence goes to the lower part of the bone as well, right? Okay. So moving on. As you guys are aware about these 4 terms, can any one of you tell me how the growth of the bone takes place, in what direction? I'm drawing a bone in front of you. Oops. Okay. I just want some quick answer, right? Just consider this is, okay, a bone. Uh, this one is your secondary structure. This one is your primary. How does the growth takes place? Is it in this direction, right? Or is it in the opposite one? This one is A, this one is B. Give me, is it A or B? Which arrow? How does the bone growth take place? Yeah, perfect. It's absolutely right. It takes place in the direction of A, the one that I just drew, right? Okay, so just a quick point for you guys, right? In the newborns, generally no secondary development is developed in any of the bone, right? But there is one exception. It is only one bone in the body which you will question yourself that why it is being developed. Can anyone tell me which bone in the babies is secondary development completely taken place? Which one is it? Is it humerus? Is it tibia? Is it femur? Which one? Okay, so just tell you guys quickly, it is the femur. That's the reason if you think, did you guys ever thought about the logic like why or how does the child can crawl? That is the first movement that you see in the child is crawling, right? So how can crawling takes place? If the secondary development is not developed in the femur, obviously he's gonna have multiple fractures, but it's not taking place. There is a reason. So the distal end of the femur, right? Basically the knee joint you can talk about, that's the distal end towards the femur. Only that section is secondary development completed in a child, right? Okay, so generally if you look at the bone structures, we have the general articular cartilage. What does the articular cartilage do? Yes, definitely it helps you provide in the joint movement, and it also helps you prevent from the friction. It helps you in easy joint movement, right? The next term is periosteum. What is periosteum? Can anyone tell me what is periosteum? Right. It is the outer covering of the bone, but there is an exception. Periosteum is not covered on one section of the bone, and that is your epiphysis. Absolutely right. That is your epiphysis. Fine. What are your Sharpie's fiber? These are just some one-liners. Okay. Okay. Basically, when you have a bone, right? So this is your bone. Imagine this is the bone. Okay. And this is the cartilage, or you can say this is the covering on the outside part of the bone. How is it attached to the bone? Through these Sharpie fibers. So got the point? Sharpie fibers, basically it's connecting your periosteum to the osteum or to the bone, right? Okay. So just a one-liner. These are some of the basic units. Might be asked as some one-liners. So just try to understand that metaphysis, as I already discussed, it is the spongy or the soft part of the bone. It is also called as the cancellous or the callus bone. Okay. Remember this point. This will be very important to you when you understand the concepts of fractures, right? And how the fracture healing takes place. These names will be coming up again and again when we'll be discussing the fractures, right? So the basic unit for metaphysis, it is trabeculae, right? Just remember it is trabeculae. Metaphysis is spongy bone. So obviously that bone won't be highly dense, right? So it's going to be less dense than the diaphysis. Diaphysis is your thick bone, or it is also called as the shaft, right? Absolutely right. It is also called as the shaft of the bone. It is also known as the lamellar or the compact bone. And the basic unit of diaphysis is your osteon, right? Okay. Now structure of a compact bone. What is compact bone? Absolutely right. That is your diaphysis, right? Okay. Now if you take a transverse section, the image that you see over here is, imagine this is the bone, and then we have taken a transverse section. We have taken a cut section, and this is the structure that you see in the bone, right? Okay. Now there are two important things might be asked as some one-liners. One is your Heverson's canal and one is your Folksman canal. Folksman canal is also important in terms of your fractures and fracture complications. We'll be discussing the different ischemias which are under the name of Folksman and how it takes place, right? Okay. Now, what is the Heverson's canal? Basically, if you cut a bone into transverse section, thing that you see over here, they are not the bullets, obviously. They are your vascular structures passing by in the longitudinal way. Now, imagine this is the bone. Okay. Imagine this is a tube. Okay. Now over here are your blood vessels and nerves passing by. Now when I take a transverse section of this is how it's visible on the screen, right? Okay, so all your vascular structures, they pass through the Heverson's canal. And what is your Folksman canal? Folksman canal is basically from your endosteum to the periosteum. So it forms a tangent. Basically, it's in the right angle, or it's in the tangent to your Heverson's canal, right? Now, the easy way to remember is, I hope everyone is very familiar with the car brand called as Volkswagen, right? So Volkswagen is what? It's a car. How does it travel? Horizontally, right? So you can just remember it by that thing, that the tangent which is formed from the endosteum to the periosteum, that section or that area into your bone, that is called your Folksman canal. Absolutely right. Okay. So this was just a quick overview. Now, just to remember how your bone ossifies and how the skeleton is formed, just by the two important things. One is your intramembranous ossification and one is your endochondral. The name itself suggests what it is. Intramembranous ossification, basically it's a fibrous membrane ossification. Now, what do you mean by the term fibrous? Obviously, it is tightly entangled to each other, right? So that's the reason. Can we see any of the joints or the movement structure on our face or skull, right? No. Okay, clavicle is one example and an exception that you have to remember. It's an example of intramembranous ossification and it's not an example of endochondral ossification. Endochondral, chondra, what does chondra mean? It's a cartilage. Rest all other joints or rest all other movements that takes place in the body, it's due to endochondral ossification of the bones. And what cartilage? Absolutely right. It's your hyaline cartilage, right? And as I've discussed about this thing, this ossification centers, basically the primary is in the center and it goes from center to the periphery. That's how the bone develops and that's how the elongation takes place. It's not from the periphery to the center, but definitely it's from the center to the periphery. Absolutely right. And I've told you about the exception. So just have a quick overview. It's the only secondary center which is developed or present at the time of birth. It's in the lower or the distal end of femur. Absolutely right. Okay, now coming to the composition of the bone, the part which I have been highlighted as your serum alkaline phosphatase, it is also important in your metabolic diseases. We'll be connecting the dots very soon. Okay. So what are your osteoblasts? Everyone knows, obviously these are your immature cells. What are your osteocytes? These are the mature bone cells, and the osteoclasts are your bone resorption cells. Basically, it helps you cut down the bone. If there is a defect in osteoclast, so obviously the bone density will increase because there is no cells to kill down, right? So that will develop into your disease called osteopetrosis. It is petrosis, also known as your marble bone disease. I don't know how to remember that, but just in case if you want to remember it in such a way, I hope everyone these days are having pets, right, at your house. And what are your floors made up of in your house? Definitely, these are your marble floors. Where do pet sit at? They sit on the marble floor, right? So marble, pet, osteopetrosis, marble bone disease, all right? Okay. So basically osteocytes, they will regulate the function of osteoblast, right? Because if you have more mature cells, obviously the body will be getting the feedback that it doesn't need any more immature cells, right? So that's how the bone development is being controlled, right? But there is an important factor, serum alkaline phosphatase. Just remember this point, which is highly seen in which cells? Osteoblasts. It's very important in terms of rickets, right? We'll be discussing that point very soon. Okay, now coming to the extracellular matrix, like how the bone structure is actually formed, right? And what collagens are involved. So generally, what collagen is majorly seen in bone? Yes, anyone? Absolutely right. It's your type 1. And the type 2 is only seen in your articular cartilages, right? Okay. So basically, the organic and the inorganic, these are the two types of extracellular matrix, right? The one third of the part is taken by the organic one, and the two third is basically your inorganic. So clinically, if you see whatever supplements that you take, your vitamin D and your calcium, 60,000 international units of vitamin D, whatever you'll be taking it once in a week, that is just improving your inorganic. Okay, that is not affecting your organic cells, right? It's formed. If it's not, it gives you certain diseases, and one of them is known as brittle bone diseases. That's the reason there is no absolute cure for brittle bone diseases apart from taking extra precautions and care for the children, right? So it's a complete triad of osteogenesis imperfecta. Obviously the bones are in not very good proportion, plus the clinical sign that you generally see, these patients presents to you with blue sclera, and they have dentiogenesis imperfecta. Basically their teeth are malformed, right? So this was just a quick overview. I know this is slightly boring, but I'll be definitely taking you to one of the important topics in terms of examination point of view. This slide that we'll be discussing will be giving you easily 2 to 3 questions, all right? Okay. Are we good? Should we move on? Okay, fine. So I'll just reduce down my speed. Do not worry, it's okay. We'll split it up if we want, but we'll try to cover up the major topics today itself, right? Okay. Okay. Okay, chalo. Moving on, talking about the fractures and splints. This slide that we'll be discussing, this will be giving you 2 to 3 short questions in the exams. Okay. Okay. So what is generally fracture? A break or a breach? Absolutely right. Everyone knows about that, right? Okay. The only thing is it might be either partial or complete. So can I say partial becomes an incomplete break, right? Okay. Can any one of you give me an example of an incomplete or a partial fracture? Can any one of you name me what fracture is it? कौन सा फ्रैक्चर है जो इनकम्प्लीट होता है, जिसके कॉर्टिकल एंड्स पूरी तरीके से ब्रेक नहीं होते दोनों साइड पे? एनी वन ऑफ यू कैन नेम मी द फ्रैक्चर. Absolutely right. That is your green stick fracture, right? Acha, what is the difference between the green stick fracture and the nightstick fracture? Anyone? Okay, I'm not talking about in children or adults. Uh, Try to give me the anatomy, because if you present to me it in the anatomical form, it's easier for you to understand and you can retain it for the longer time. Absolutely right, good doctor. It affects your ulnar bone completely, right? And also in major cases, we also see there are cases that we see where the radial head is also involved in that. Okay. Okay. All right. And the most common sign, remember, in a fracture, it is the tenderness and it is not the pain. Pain comes later on, right? Okay. So this is the thing I was talking about, that remember the names and what is a metaphysis known as, what is a diaphysis known as, and we will be discussing the stages of fracture healing. Okay, so let's quickly revise. I hope everyone knows about it. What is the first thing which happens when an injury takes place? Definitely, it is hematoma formation, right? After that, the new vessels will grow up. Basically, the macrophages comes into the picture, है ना? So that is your stage of granulation tissue formation, right? तो उसमें दो होता है, granulation tissue is soft and one is your granulation tissue which gets mineralized, which is hard or which is known as callus. अच्छा, कोई बोल सकता है कि callus bone किसको बोला जाता है? हमने अभी डिस्कस किया था callus और cancellous bone. Is it the metaphysis or the diaphysis? Absolutely right. It's your metaphysis. ठीक है. फिर metaphysis basically it's your soft bone. वो धीरे धीरे mineralize होगा, right? After that takes place your fourth stage, that is your remodeling. After remodeling, what takes place? It is a modeling. Modeling is a stage. If you see it radiologically, it's absolutely indistinguishable. मतलब मान लो कि आपके पास एक patient है with a history of fracture 8 years back. Because in adults generally that's the amount of time which takes for modeling, right? ठीक है. तो अगर उसका आप ह्यूमरस बोन देखते हो जो 8 साल पहले फ्रैक्चर हुआ था या 10 साल पहले फ्रैक्चर हुआ था, उसको आप 10 साल के बाद रेडियोलॉजिकली देखोगे तो यू कैन नॉट डिस्टिंग्विश कि शायद वो बंदे में कभी फ्रैक्चर हुआ था या नहीं हुआ था, इफ द फ्रैक्चर हैज बीन रिजॉल्व प्रॉपर्ली, राइट? सो दिस इज व्हाट I'm trying to mean by these different stages of fracture healing, and it is very important because जो भी complications हैं आपके fracture के, it takes place only if any of these stages has been skipped, or say if any pathology takes place, or if there is any kind of malunion or non-union, you know. So all of these complications in fracture healings, right, it only takes place after these stages, right? So what happens in the first stage? That is your hematoma formation. So basically the blood vessels are erupted. So what's going to happen first? It's the hematoma, right? After that is the stage of granulation tissue. So granulation tissue basically is what? Fibroblasts are a form of what? These are your macrophages, right? So fibroblasts plus osteoblasts. Now everyone knows osteoblasts are your immature cells, right? So together they club and they form the soft tissue of the bone, right? It is also known as the neoangiogenesis. This stage takes place between 7 days to 3 weeks, right? And the next one is your granulation tissue. Granulation tissue mineralized. This is the thing that I was talking about, and it is a very important stage because this is the only stage which is radiologically visible. Basically, where your fracture healing takes place, that you can make it out radiologically, that will be only at the end of 3 weeks. That's the reason जब भी हम प्लास्टर लगाते हैं, we do not take immediate x-ray. Why? Because the healing takes place and it takes time. So basically when it's visible on an x-ray or on a screen to the human eyes, that is definitely through the x-ray, and it is only visible at what time? At the end of 3 weeks. Absolutely right. Okay, and after that comes your stage of remodeling. Now remodeling is between your 3 weeks to 4 months, and later on whatever stage it is between 10 to 15 years, that is the stage of modeling. Modeling is basically you cannot distinguish between the intact bone or this bone was fractured before or it has a history of fracture, right? Okay, so moving on, can anyone tell me what fracture is this? Absolutely right. This fracture healing stage takes place in children. On day 1 itself, you can see hematoma formation, right? On day 4, generally in adults, it takes place on what day? Right, 7 days to 3 weeks. The granulation tissue forms in adults on 7 days to 3 weeks. In children, it forms as early as on the day 4, right? And on day 7, over here, callus formation takes place in adults. Absolutely right. It takes place at the end of 3 weeks, right? And the remodeling in adults generally takes place from anywhere between 3 to 4 months. That's the rough time that we consider, right? But over here, it takes place as soon as 2 weeks. Just look at the modeling. It's happening as early as within 6 months. But in adults, it's happening what time? 10 years to 15 years, right? Let's have a recap. Stage of hematoma formation in adults, 7 days. Granulation tissue, 7 days to 3 weeks, right? Callus formation happens at the end of 3 weeks. Remodeling between 3 weeks to 4 months, and stage of modeling 10 to 15 years, right? Okay, what is the most common cause of fractures pathologically in humans? It's absolutely right. That is your osteoporosis. Basically, what is osteoporosis? Decreased density of bone. Anyone can tell me what is increased density of bone? We just had a discussion. What disease has got very high density of bone? It's a pathology. Osteopetrosis. Absolutely right. Manen Mathur, you're absolutely right. Okay, moving on. There's so many other reasons for fractures, right? So you guys can have a read about it. We'll just quickly look at the classification and how it is related, right? So one of your important classification is your Gastillo and Anderson's classification. There are basically 3 stages: stage 1, 2, 3, 3A, B, and C. Okay, I hope you guys are very much familiar with this. Okay, so what is this stage 1? Basically, the wound size is less than 1 centimeter. In stage 2, the wound size is between 1 to 10 centimeters. In 3A, B, and C. In A, what happens is basically you have adequate soft tissue coverage. In B, your soft tissue coverage is lost. So basically, how do you reconstruct or how do you fix those fractures is by covering it up by flaps, right? Which one is externally related to the environment? Which stage of the fracture comes in the contact with the external environment? Which stage? Absolutely right. That is your stage 3C. So if you look at the management, right, debridement basically is just you're wearing off the dead tissue and then you're internally fixating it. You don't need to cut open and you don't need to fix it externally, right? So only in one fracture we need to externally fix it. That is your 3C, because it is associated with vascular injury and the complete soft tissue coverage is lost over there, right? So the treatment over there is debridement plus external fixation. Absolutely right. This is how it looks like. This is your stage 3C. Okay. Okay. These are 3 types of fractures. Can anyone tell me from A, B, and C, basically the transverse, oblique, spiral, which one is the easiest to break and which one is the most difficult to break? Absolutely right. It is the transverse which takes the intense strength to break. So generally, these are the fractures that we see if we see a road traffic accident into a young individual. It comes with a femur shaft fracture. Now understand how strong the femur bone is. And if the shaft is broken, it cannot just break with a fall, right? Definitely, it needs a very high intensity velocity to break that. So that's your transverse fracture. When it comes to the spiral fracture, it is much more commonly seen in older adults. Right, a fall maybe in the bathroom, right, or a fall from the stairs. These are the common fracture in the old adults that we see as the spiral fracture. Now when it comes to the healing, which one will heal first and which one will heal the last? Yes, it's absolutely right. It's very obvious. The one which takes the highest velocity will take the highest time to heal. So the transverse will heal the last, the spiral will heal the first. So I'm just showing you up the slide, right? So if you see it over here on your screen, I'm sure you guys must be aware that I'm proving my point over here, right? Okay. Now, anyone coming to the business, right? These are some of your important exam images that you'll be seeing on your screen on 18th of June. Let's have a discussion about it. tell me what fracture is on your left and what fracture is on your right. Or rather, what is A and what is B? Can anyone name me what is A and what is B? If you understood that thing right, or if you guys just answered the first question of this topic when I asked you about the partial fracture or the incomplete fracture, you can make it out. Okay, someone said B is green stick. Absolutely right. Okay, so the B is green stick, and what is A? Okay, this is the fracture I was talking about. Okay, if you look around over here, you can see only one cortical end is distorted while this cortex is intact. So this becomes your green stick fracture. Absolutely right. Over here, can anyone tell me what bone is this? This part, what bone is it? Is it radius or is it ulna? Okay, absolutely right. That's your ulna, and this is your nightstick fracture. The A that you see on your screen, it is your nightstick fracture. Okay. Yes, we'll be coming to Galeazzi and Monteggia as well. Just try to understand what's the difference. Over here, what you see on your screen is both the cortex or both the cortical ends, they are distorted. But over here, one is intact and one is distorted, right? Okay. Can anyone name me what fracture you see on your screen? I'll give you a very good hint. It's the styloid process of your radius. What is the name of the fracture? Come on. No, it's not the scaphoid. It's the styloid process of the radius, sir. Can anyone name me what fracture is it? It is absolutely right, Kanika. It is Schaufer's fracture, right? It is the Schaufer's fracture. Basically, it's named because, when you drive the car, what bone is over here? It's the radius, right? So when you drive the car, what does the chauffeurs do? They park your car, right? Or they drive it for you. So that's the reason these injuries towards the styloid process of the radius, they're named after them. They're called the Schaufer's fracture, right? Okay. Now, what is happening over here? Can anyone tell me into the picture? What bone is it? Is it tibia, fibula? What is it? Tell me, what is it? Okay. No, sir, it's neither tibia, it's neither fibula. This is an absolute X-ray of an arm and a forearm, okay? But can you notice one thing? If you look over here, the bone is missing over here, right? If you look carefully over here, but there is only one part of the bone which is left. How is it possible? Obviously, the bone is exposed to the external environment, right? So in what fractures do we see this? It's generally seen into children more commonly. आई होप यू गाइज रिमेंबर, बचपन में तो याद किया ही होगा, है ना? मॉम डैड बोलते थे कि गाड़ी से हाथ मत निकालो बाहर. दिस इज द थिंग विच हैपेंस. इट इज कॉल्ड एज योर साइड स्वाइप फ्रैक्चर, राइट? इट्स जनरली सीन इन children or the baby calf fracture. Okay. Now when you look onto this one, I hope this one is very clear to you that it's a femur, it's a tibia, and it's a fibula. Can everyone make out these three bones? Perfect. Okay. What is the name of the fracture and what side is affected? Can anyone tell me, is it the lateral or is it the medial side of the tibia which has been fractured over here in the picture? Come on, this is just a quick revision for you guys. Absolutely right, Kanika. Absolutely right, Sandeep. Man, it's your bumpus fracture. Absolutely right, Kanika. It's the lateral aspect which is involved. That is your bumpus fracture. Basically, if a car hits you, the name itself suggests you, it's going to hit you towards the knee, right? That's the level where the bumper of the car is. That's the reason it is named as bumpus fracture. Moving on. Okay. What fracture is this? Okay, basically, I'll just give you a hint. There are two malleolus, right? One is at the lateral aspect of your tibia and one is at the lateral aspect of your fibula, right? So both of these malleolus, when they're fractured, it is called a bimalleolar fracture. What is the name of this bimalleolar fracture? Absolutely right. This is your Potts fracture. Remember Potts? Pot has got how many T's? Two T's. It is bimalleolar fracture. How many T's in Potts? Two T's, right? So that's how you can remember, because it's very confusing. You have another fracture. This one is your trimalleolar. If you can look over here, this is the AP and the lateral view of the leg, right? So you can see both the lateral and the medial aspects are being fractured, and also the posterior part of the tibia it's being fractured. It's a trimalleolar fracture. Now, what is a trimalleolar fracture called as? Absolutely right. This is your Cotton's fracture. Okay. Don't worry. We'll be revising these things again and again. I know you cannot just remember all these things in one go, but this is the high time and we have to know and we have to mug this thing up. I know there is no clinical significance behind the names, but then you can have your own ways to remember it. But just try to remember what fracture is what, because they'll be asking you at least one or two questions in the exam based on the fractures, right? Okay. Now, if you look into the picture, anyone who can tell me if it's an intra-articular fracture or an extra-articular fracture, and what do I mean with that? Okay, basically intra-articular is when your joints are disrupted, and when it's an extra-articular fracture, that means where only the shaft or the bone is affected, but the joint space is absolutely intact. So can anyone tell me what kind of a fracture is this, intra-articular or extra-articular, and what is the name of the fracture? Absolutely right, Yogesh. It's an intra-articular fracture. Can you try to name what is the name of the fracture? This is generally seen in crush injury or a fall from a height, right? When you see an individual falling down from a height, this is the kind of a fracture that we expect, and it is known as the pylons fracture, okay? Just try to remember, you pile on something to fall, right? Pile-ons fracture. I don't know. I know it doesn't make any kind of sense, but then this is the way you'll have to remember it. It communicates with the joint, right? So generally seen in fall from a height. Okay. What anatomical bone structure is disrupted over here? Absolutely right. That is your talus. That is, you can see it on the screen. And we generally fix it by internal fixation with screws, with reduction and fixation. That's how we generally fix these kind of fractures, right? Okay. So this is known as the aviator's fractures. Okay. Okay. If you look into the picture, I don't know if it's very clearly visible to you or not, but I'll give you a very slight hint. This is the part which is affected, which is the metatarsal which is affected. It's the fifth metatarsal joint. Okay, and there is a name for this fracture. There are two different kinds of fracture. One is generally which occurs at the second or the third metatarsal joint, and one at the fifth metatarsal one. This is at the fifth metatarsal joint. Can anyone tell me what is the name? It's absolutely right. This is your Jones fracture. Just remember, this is much more common in athletes. Now, everyone knows the brand Jack and Jones, right? So remember, athletes wear Jack and Jones. That's how you can remember Jones fracture, seen in athletes, right? Okay. Okay, let me show you this image so you get a clear idea. What is the bone? Is it the C1 or is it the C2? Which vertebra can you see on your screen? Absolutely right. This is your cervical 1. It is known as the Jefferson's fracture. Okay. Arc of C1. Okay. What is... Okay, just a second. फैन बंद हो गया वो बीच में
नेट का इशू है शायद। ना सिम इज गोइंग
जी।
Sometimes it
वन
happens.
नोट वन नोट
वन नोट में स्टार्ट हो गया
इसको पॉज कर दो फिर।
ना ना उसको चैनल देखो देखो बंद कर दे तेरा वन नोट नहीं तेरा तेरा तो वाला था ना
वही ओपन था, बंद हो गया फिर से साइन कर।
कौन कर ये वाला आ गया
हाँ ठीक।
और इसको निकाल
Okay, chalo, perfect. Sorry for the interruption. There was some technical error. Okay, moving on. Okay, so this is the fracture of C1, right? Arc of C1. Okay, can anyone tell me what bone or what structure is over here in front of your screen? The one that I've just encircled. Hmm. बड़ा ध्यान दे रहे हो इधर उधर. Okay, it's absolutely right. This is your C2, and the thing that you're seeing on the screen, which I've just encircled, it is the dens. It is the part of your C2. Basically, that helps you in the Indian way, the yes and the no, basically the no movement. This happens because of this structure that you see on the screen, right? It is called the dens. Okay, just a quick overview. This is the vertebra. Basically, you have the anterior longitudinal ligament on the screen, the posterior, the annulus fibrous, the nucleus, basically which comes out of the annulus fibrous, and we have the facet of the joints. Can anyone tell me from where the joint movements takes place? Is it from the anterior longitudinal ligament or the posterior longitudinal ligament, or from where? Absolutely right. That is from the facets of the joint. So basically, when you move down, or when you try to bend, this bending movement takes place from where? It takes place from the facet of the joint. Absolutely right. Okay. Okay. What is the image that you see on the screen? Anyone can tell me what radiological investigation can you see on the screen? Is it a CT scan or is it an MRI? Absolutely right, Faizan. It's a CT scan. And how can you say it's a CT scan? Because you can see the cortex, right? The white structure that you see over here, this is the cortical end of the bone, right? These are the spinous process of the bone.
It's here.
Okay. So the fracture that you see in front of your screen, it's a chance fracture. I'll just tell you in short that how it happens. It happens generally in the car accident. If you see over here actually both the wedges are involved. Basically, this is the anterior wedge we call, and this is the posterior wedge. Wedge is nothing basically, just the vertebra. We call it just as a wedge in terms of reference. And when you have fracture over that, this is absolute horizontal fracture that you see. It is called as the chance fracture. Now, how do you remember that? Okay, I don't know how you'll remember that, but you gave someone a chance to drive the car and That's how he went under an accident or she went under an accident. This is generally much more commonly seen in under seat belt injuries, right? This is the chance fracture generally we see in the car accidents. Okay. What is the name of this fracture and how do you differentiate it from the chance? Okay, sorry. Okay. Okay, over here, this fracture that we call, it is as the burst fracture. Now, if you look at the vertebra over here, this one is absolutely intact, right? But if you look over here, just try to pay attention. If you look over here, the height is decreased, right? The height is decreased and the width is increased. Check the width of this vertebra. Check the width of the vertebra which is right above to it, right? So this is generally much more common under burst injuries or when you fall from a height. This is the kind of wedge shape that you see on the screen, right? Okay. Okay. Moving on, there is another fracture that you see. It is known as your Clay-Shawler's fracture. Clay-Shawler's fracture is basically the translation of your C7 vertebra, or basically C6 over C7 or C7 vertebra over C8. Generally, C7 vertebra is much more common than the dorsal or the thoracic first vertebra, right? Okay, now what do you mean by Clay-Shawler's fracture? Basically, Clay-Shawler's is nothing but हिंदी में जो बोलते जो कूली या जो workers, laborers जो काम करते, right? So they hold it up, the bags like this with the pressure, right? So basically this is the only fracture जो physical injury से नहीं होता है and where your muscle involvement takes place, right? So basically this happens, why? It's not because of any kind of a trauma, but it is due to the spasm of your trapezius muscle, okay? Okay, moving on. This fracture that you see is your Hangsman fracture. This is translation of C2 over C3. Which one was the fracture of C1? Right, Jefferson's fracture. Okay. Now moving to the next one, this is one of the important fractures, which is much more commonly seen in the dashboard injuries. Okay, this is also seen in under the car accidents. Okay, now what happens over here is basically if you see the femur, right, it's been dislocated towards the posterior aspect, right? And if you look over the femur, this one is intact in the ball and socket joint, right? But how can you say it's been distorted? There is one criteria that we look for. Always just try to look for an arc. Can you see this arc complete? No, it's been distorted. Now that thing is called your Schenkten's line. What is it called? Schenkten's line. Okay. So basically, what happens over here? We see Schenkten's line. Now, when Schenkten's line is distorted, that's a crystal clear indication that your hip joint is dislocated to the posterior aspect. Okay. Okay. Now, these were some of the important fractures. We'll be revising it again. Now, coming to the splints. One of your exam questions will be asked on the splint. Okay, these are some of the very common ones. Generally they don't ask you in the exams. We know the K wire or the Kramer wire we generally use to immobilize the patient in emergency situation. Absolutely right. Okay, the next one that you see on your screen, it is which one? The Thomas splint. As we know that Sir Hugh Thomas Owen, he is also known as the father of British orthopedics, right? It's been designed by Sir Hugh Owen Thomas, right? It is used in femur and hip fractures, okay? This is the Thomas splint. This is the K-wire splint, okay? Okay, all right. Now, this is your congenital Talipes equinovarus. Now, what do you mean by CTEV, varus? What is the term varus and valgus? Let's try to understand this thing in a very simple way, okay? Now, varus and valgus. I'll just try to make you remember it in an easy way because I know this is the end time of your preparation and you don't want any extra burden. Now, R is what? Just remember R is reduced or reduction. L is what? Long or increase in the length. Okay. So when the angle gets decreased, now this is, say, this bone is your humerus, this is your ulnar and radius. Okay, now this is the angle plane. Okay, now if this angle, if I take it from here, this gets decreased, if it gets acute less than 90 degree, or if it starts to reduce, that is your varus. Okay, now if this angle if this angle increases, now say this is the joint. Okay, it is increasing, right? This is the angle, this is becoming roughly around 120 degree, so that becomes your valgus. Okay, this is just a very quick way to remember your varus and valgus. Remember, R comes in varus, so that is, I'm really sorry, I don't know why it's crashing up again and again. Okay, moving on, we'll just try to complete these couple of splints, and then we'll just take a short break, and I'll see what kind of technical issue that we're facing over here. All right. Okay, I'm really sorry for the interruption. Okay, so the splint that we use over here is Dennis Brown splint, right? Dennis Brown splint. This was one of the exam questions, not this time. I think so it was a previous August exam attempt question. Okay. Okay, moving to this one, this is your cock-up splint. You have your wrist drop deformity. Basically, wrist drop, what do I mean by the wrist drop? Basically, the hand goes down. What nerve is involved into this defect? Can anyone tell me? What nerve is involved when I talk about wrist drop? Absolutely right, sir. Absolutely right, Kanika. It is the radial nerve. Can anyone tell me the name of two muscles which are on your screen? What do you mean by ECRL and ECRB muscle? Absolutely right. These are your extensor carpi radialis longus and extensor carpi radialis brevis, the long one and the short one, right? These two muscles are supplied by that one. Extension. Can I say this is flexion and can I say this is extension, right? So when the radial nerve is involved, its role is to supply extensor carpi radialis longus and brevis, right? So this is extension. So if radial nerve is involved, obviously this action won't take place, and that's the reason the patient is having a wrist drop. And that is the splint that we use. Okay. Okay, just couple of more, and then we'll just try to fix this issue. Okay. Another one is your knuckle bender splint. Okay. Knuckle bender splint. What nerves involved partial claw hand? Can anyone tell me? And when does complete claw hand occur? Absolutely right. When your ulnar nerve is affected, this gives you the partial claw hand, and when you're complete, both the median and the ulnar nerve, both of them they're affected, that will give you complete claw hand, right? So this splint can be used in either of the situation or either of the cases, knuckle bender splint, right? Okay. Now this is one of the very important splints, and remember I was talking to you about the Folksman canal. What is the Folksman canal into the bone? Absolutely right. It carries your vascular structures, the nerves, right, and the blood vessels. So if you have a look into it, Folksman ischemic contracture, what do you understand by this term? Basically, this is much more commonly seen under compartment syndrome. When you try to put up a plaster which is not completely fixed up in a proper way with the proper gaps, so basically you're just compressing the fascias, right? So what do you have? The osteofascias. Basically what I'm trying to tell you is the bones and the fascia. Fascia is basically what? It is covering up your blood vessels, right? Right? So when your blood vessels are involved, obviously it's going to affect the muscular structures as well. And what happens into this situation is when you have compression syndrome, right? So what happens is basically your fingers won't move. Initially, the patient will have burning sensation and it will lead him to severe intensity of pain. Now, this action, can I say it is flexion, right? So what muscles or what part of the forearm are associated with flexion? This is your anterior aspect, right? Not the posterior one. So over here, these muscles that you see, basically these are your flexors. So basically your FDP, flexor digitorum profundus, right? It is connected at the medial aspect right, of the humerus. So basically what we do is generally we just try to fix this patient with his splints. What happens is eventually we keep on increasing the strength, and that's how the patient tries to regain its finger movements. If this has not been done by this splint, what happens is we cut open the patient, we do a surgery, okay? We just try to cut down the muscle fibers, and that's how we try to relax the patient, the flexor FDP muscle. We just try to make a slit over there, and then that's how the patient regains its movement, okay? Okay, we'll come on to this one. This is one of the very easiest and the common one. When you have deltoid paralysis, right? Which nerve is involved, or what plexus is it? Absolutely right. That's your brachial plexus. So when your brachial plexus is involved, what nerve is affected? I'm really sorry for this technical error. Okay, it's your brachial plexus lesion, right? And what is the name of the splint? It's the aeroplane splint. Okay. Now, when you see this brace, it is generally used for the spine or the spinal surgeries, okay? What is the name? It is absolutely right. This is your Taylor's brace. Absolutely right. For Priyadarshini, that it's the axillary nerve which is involved when we use the aeroplane splint or when there is defect in the brachial plexus. Absolutely right. Okay. So this one is also used for TB spine, but generally when you have a back injury, this is the brace that we generally use, okay, in those patients. Any of the thoracic or the lumbar vertebra injuries, we use those splints. Okay. Okay. This is again one of the most important splints which we generally use in scoliosis. It is the Milwaukee's and the Boston's brace, okay? Okay, the CPN or the foot drop deformity, okay? Which muscle is basically paralyzed? It is the, absolutely right, it is the anterior tibialis, okay, which is paralyzed over here. So generally we use this splint. It is also called as AFO or the foot drop splint that we use, okay? Okay, this is one of your exam questions which came recently as well. Do not get confused with the Dennis Brown splint. Have a look. Dennis Brown splint is for CTEV, right? And if you look at this one, it's just the last one. Come on, just don't want this computer to give up that easily. Okay, all right. So now if you look into this one, this is your developmental dislocated hip, and the splint that we use is Barlow's splint or the Pavlik's harness. The Dennis Brown splint was used in CTEV. Absolutely right. Do not get confused. Have a look into these pictures when I share these slides with you, so you guys have the absolute clear idea. Okay, when we talk about these kind of tractions, we will be talking about them in the upper limb and the lower limb trauma. Just try to know the names so you will come to know what I was talking about. Your Gellav's or, oh God. Okay, your Gellav's or Bryant's traction generally we use in children less than 2 years in case of lower limb trauma or the shaft of femur fracture. So what kind of fracture will be when it comes to shaft of femur fracture? It's going to be absolutely right. It's going to be a transverse fracture, right? And it will require immense strength. But in case of children, it won't require that immense strength because their bones are not that developed at that point of time, right? It takes some time for them. Okay, when it comes to another traction, this is generally we use, it is called as Dunlop's or Smith's traction. We generally use in supracondylar fracture, or when the children have the fracture on the lateral aspect, lateral condyle of the humerus. And there is one point to remember just as a one-liner, that the lateral aspect of the humerus or the fracture which is associated with the lateral aspect of the humerus, it is your intra-articular fracture. What do I mean with that? Intra-articular fracture means basically when your joint space is involved, right? Okay, and generally those fractures are really hard to fix. Okay, I think we'll just take a quick short break. Let me just try to fix this issue and then we'll start with the complications and the upper limb and the lower limb trauma. Okay.